We are live now.
Okay, good evening, everybody. Welcome again to this program brought to you by the Orthopaedic Research and Education Foundation. Today, we have the pleasure of having Dr. Hitesh Shah, Professor Hitesh Shah, should I say, back with us today. And he's going to take us through some pediatric case-based discussions, and which I'm sure you're going to find useful. So I think I don't need to introduce Hitesh anymore. He's been many times on this webinar, and over to you, Hitesh.
Good evening. Thank you. Thank you, Dr. John, for the introducing. So without wasting any time, so I can share my screen. Is it visible?
Yes, sir.
Yeah.
Thank you. So we thought we are going to discuss some of the cases, which is just excuse me, by the way. Some of the cases which is actually not covered before that, I am going to include that. Okay. So the most common question so today I'm going to have some of the case scenario, some of the practical things, and some of the OSCE question, which is actually commonly asked in the DMB question. Similarly, some X-rays, which is also very useful for the table, because table will get the X-rays. So the question it's going to ask by the most of the examiner, and if you see any patient day by day in practice, these are the four questions we are going to ask first to us. If we can get the answer, we can prepare the answer and give it to examiner. So whether it is the exam or a post-exam, we are going to have the same question. What is actually the diagnosis of this patient? Why do you think so this diagnosis is there? What should we do for this case? Why should we choose this particular option for that? And how should we do that? These are the four questions we need to ask that, irrespective of the case, whatever we are going to face there. Okay, so if there are some postgraduate are there, when we are going to have a scenario that we are going to have that, what is the diagnosis? What will you do? Why it is like this? How will you do? So one of the common scenarios in the exam and day-by-day practice is the pediatric bony swelling. The approach to the child with the bony swelling. So it is very common to have the bony swelling, and it may be there in any part of the body. It may be very common to have a distal femur or proximal tibia, or it may be having in upper leg. So it is going to discuss. First, I'm going to say the few slides and say what are the very relevant history. Then I will take a pause and have some of the important findings. Okay, so very common to have a pediatric bony tumor. So it's like this child is there, the 15-year-old child is present with the distal femur, the swelling, bony swelling. So what are the very relevant or important question what we need to ask in history? What is the age of the child? Because most of the time these are the short case. Very commonly kept exam is the osteochondroma or the malignant tumor as the osteosarcoma. So very common to have that. What is the age, whether it is in first decade or second decade, because having sarcoma is common in first decade, while the osteosarcoma is common in the second decade, and the osteochondroma is common in the both decade, many benign or the malignant tumor. The onset, duration, and progress of the swelling will give you an idea whether it is a long-standing or a short duration history. Always the long-standing is the benign tumor, while the long-standing would be the malignant tumor. If it is associated with the pain, because this is a very important feature, the pain before the onset, before the swelling appears, that suggests the osteosarcoma. And pain after long-standing swelling, that suggests about the benign in nature. But the pain and swelling together, you can have the having sarcoma or all other malignant tumor. And the third important symptoms is the deformity. If it is associated with deformity, upper limb, it can have a manus valgus or manus varus. While in lower limb, it may be having genu valgum or varum. It will be present with the deformity or not. The most important is that what is concerned for the parents and the patient? Is it a function or the cosmetic? Many times that will be bothered to find out whether this is what kind of tumor is there. And the most important, is there any one swelling or multiple swellings are there? So if there is a single swelling, the diagnosis would be different than there are multiple swellings.
You've plugged into Nirvana. Your device is ready to pay.
The diagnosis would be different. So at the end of the history, whenever there is a bony swelling is present, we can able to define whether it is a benign tumor or a malignant tumor. And many times some of the senior examiner will ask, these are the questions. What question is there? What kind of etiology is there? And most of the time, the student will answer, is it a congenital, developmental, traumatic, metabolic, infective, or inflammatory? Whenever there is a bony tumor would be present, the most common diagnosis is infection, not rest of them. Rest of them would not be present. The neoplastic will always have with infection. Either it would be a joint, then inflammatory would be there. Rest of them would be just a theoretical. In a practical life, whenever we see that, we'll see either the infection or a tumor that would be mimicking each other. Then comes for the benign and malignant. As I said that when there is a short duration history, you can think about the malignancy. Whenever it's a long history, that will come as the benign in nature. Whenever there is the presence of the location of the tumor is in metaphysis, there are certain tumors like osteochondroma, osteosarcoma, simple bone cyst would be common in metaphysis. Like some of the artificial tumor like a chondroblastoma is common in epiphysis. While some of the diaphyseal tumor is like the Ewing sarcoma is common in the case of the diaphysis. Infection also will be mimicked like a diaphyseal tumor. The age-wise differential diagnosis would be, as I said, osteochondroma and the simple bone cyst is very common in first 2 decades, while the Ewing sarcoma is common in the second decade, while the Ewing sarcoma is first decade, osteosarcoma is on the second decade. Important to do the general examination, general physical examination, where there is, wherever there is a general physical examination, bony tumor, always check about the detailed general examination. And that includes the head-to-toe examiners and find out whether it's a single swelling or a multiple swelling. Okay, so this is the when we are seeing about the case, similar say the case, the 15-year-old child present with the long-standing history, the 8-month history, and it's a painful. So that's what we need to check and look. Whenever you say about the gait, whether it is dentalgic or a non-dentalgic, how is the mechanical alignment? What is the discrepancy? As we see in the swelling, we need to define exactly what is the site of the swelling, what is the size of the swelling, how is the surface of the swelling, it's a well-defined or ill-defined. What is the skin, whether skin is normal or not. In case of the malignant tumor, the skin would be slimy, skin would be tight, it will be having the varicose vein or dilated tortuous vein is there. Anywhere we'll see the dilated or tortuous vein with the shiny skin, it will give idea about the fast growing tumor and indirectly suggestive of the malignancy. While vesting is showing that is short duration history cannot be taken with the vesting, is always a long standing. And we need to say about the pressure effect of the tumor. That is very important when we see about the look. When we see about the fill, we need to see about the temperature and tenderness, whether it is well defined or a poorly defined, whether it is a single swelling or multiple swelling. Even though you present with a single swelling, but that may be having multiple swelling. Single swelling, you can differentiate between the benign and malignant. While if you see about the multiple swelling, you can think about the hereditary multiple exostosis. See about the surface, whether it is smooth and regular or if it is irregular. Most important part in the bony tumor is a consistency. If there is a consistency throughout is bone, then it would be the hard. Where in between, if you see about consistency is a soft, either it would be fast growing tumor or something else. That will be differentiated between a soft tissue tumor and a bony tumor or soft tissue tumor by the bony tumor. Skin, whether it's a pinchable or not, most of the benign tumors are pinchable or not involvement of skin. It will give you an idea whether the skin is involved or not. Status of muscle means when you're contracted, whether it is deep-seated in the bone or not, and palpable pulse, whether it is a pulsatile swelling or not. Very standard way of checking about the range of movement, the nearby joints like a distal femur, you need to check about knee and the hip joint movements and measurement exactly is there any movement discrepancy. Always do about the distal neurovascular examination. So coming back to this case, there is if you see about this child was walking normal, alignment was normal, limb length discrepancy was no. There is a 4x4 size swelling, surface was smooth, skin is normal, no wasting, no pressure effect, no tenderness, it's a well-defined swelling, surface is smooth, the consistency of this bony hard, deep-seated from the medial aspect of the distal femur, skin is pinchable, and it's below the adductor magnus. That's the palpable pulsation is not a pulsatile. So any distal neurovascular is normal. So any postgraduate, anybody is volunteer can say what could be the diagnosis?
Most probably, sir, osteochondroma.
Okay, most probably osteochondroma. Anything else other than that?
Yes, Samay.
Secondly, I'll keep giant cell tumor.
Okay, giant cell tumor is an epiphyseal tumor, and giant cell tumor doesn't appear in metaphysis. So, okay, so giant cell tumor doesn't appear in a metaphysis. So what does mimic in case of the anterior aspect of the distal bar? Something in a muscle can convert in the bone. Something in a muscle can convert in bone. Something looks like the mass.
Yes, Avinash. I think we have Avinash, Neeraj, and Sachin.
Okay.
Yeah.
Repeat the question. Your voice was breaking.
Okay, my voice was breaking. Okay, is there any muscle that will convert into bone? Something is near diagnosis.
So one answer we got is myositis.
Okay. Okay, so it's myositis. It's nearby, but that is called as heterotrophic ossification. It is also very common around the joint. Okay, and very, very common to have that is that something called as calcification, that is called as tumoral calcinosis. It will be look like a bony heart. So wherever somebody is going to ask, most of the time you are correct, is absolutely correct. That's the multiple osteochondroma or a solitary osteochondroma. But somebody is going to ask, what are the differential diagnoses of the osteochondroma? Something like a osteochondroma like tumor, that is benign tumor. Either it comes of the myositis ossificans, or the new name is called as heterotrophic ossification, but it would be relevant to muscle. And second is the tumoral calcinosis, where there is an extra osseous ossification would be present.
Sir, one answer we got is chondrosarcoma.
Okay, you can see about the chondrosarcoma. Yes, that is very absolutely, I cannot say it's absolutely wrong, but the person who gave that, is it Sachin, correct? Chondrosarcoma.
Yes, sir.
So
Sachin.
what are the differential diagnosis of chondrosarcoma versus osteochondroma?
Yes, Sachin, it is for you first.
It's correct. I'm not telling it's wrong. It is correct. Chondrosarcoma is one of the differential diagnoses. It's differential, but there is a peculiar pictures that you can have that because many times examiner will ask, why not this is a case of chondrosarcoma?
Yeah.
I will show you some example also.
May I answer?
Yeah.
So osteochondroma, it grows away from the joint, sir. Chondrosarcoma is probably near to the joint. That is one of the.
Actually, chondrosarcoma, that is, I'm not talking about chondroblastoma. This is chondrosarcoma. Chondroblastoma, which is actually very common in the epiphyseal tumor. Okay. This is also, it's a metaphyseal tumor or epiphyseal tumor, but
Yeah.
chondroblastoma whenever the osteochondroma can convert into malignancy, that is the commonest malignancy is chondrosarcoma. So the long-standing osteochondroma, particularly, I will have that slide also, I'll show you that. When particularly person will have a pain, remember that, there is an acute onset of pain. There is a severe intensity of pain. Second, acute increase in size. Third, sudden enlargement of the size and short duration. Third, there is a X-ray shows there is a calcification in the cap. There is a chondral cap, that is where the cartilage is capped, and it would be detected in X-ray. That is a more than 5 millimeters. You can suspect about a chondrosarcoma. Okay, somebody is going to ask that question also. When will you suspect a case of the chondrosarcoma? But in this particular case scenario, yes, whenever you say about that, I will show you that what to say in your exam also.
So the first differential, what it should be for this one, and if for 2 to 3 differential, where chondrosarcoma we can.
I personally also agree with the first answer. The first answer, you can say this is my first diagnosis. Don't say about differential diagnosis in this.
Yes.
This is the case of solitary osteochondroma of Blythe distal femur without any complication, without having pain, without restriction of range of motion, without deformity, neurovascular normal, uncomplicated case of the osteochondroma. You can say this particularly. And the particularly important in justification, because aldolation in nature, insidious onset, is it a slow growing, is it simple, is it painless, immobile to the bone, if the bone swelling is the 3x3 with a smooth surface, with superior margin, and it is merged with the bone. That is most important. Whatever you see about heterotrophic or that, it would not be merged with this one. And well-preserved joint movement, without any deformity, without limb-length discrepancy, and distal neurovascular. These are the very important points for the postgraduates who are appearing for exam, because these are very important common scenario. Wherever you see any swelling, that would be because benign tumor. Somebody is going to ask, why do you say only one? You can say benign. This looks like a benign tumor arising from bone, and it is the commonest. The age is matching, site is matching, distal femur is matching, the slow growing, it's a smooth margin, and it is continuous bone. So most likely to be osteochondroma. Okay. If somebody is going to ask what are you going to see that, then you can say about the differential. Don't say first primary, because very common to have pulling about that. What else? What else? What else? Then you can say I am going to check this, because some of the examiner will ask why need to do about journal examination. Journal examination find out whether it is a solitary or a multiple, whether the first toe, great toe is small, or the hand thumb is small or not. If it is the small, you can think it's that fibrodysplasia ossificans progressiva. This is also one of the differential where you can have the extra mass of the bone. But this is a benign tumor. You can say it's a benign tumor arising from distal femur, most likely to be osteochondroma. Okay, so it's always seen about the benign tumor, exopathic distal femur, most likely to be solitary osteochondroma. So second question to all, what will you do? Very simple question.
So I would like to investigate in the form of radiological investigation.
What radiological investigation?
I would take radiograph of the involved knee joint, AP view, and lateral view.
Okay, perfect. That's actually the perfect. Okay, the most of the time this is the commonest question, and this is the commonest correct answer. That is, we need to proceed with the radiograph, particularly for the anteroposterior and lateral view. So, can anybody read? Can you see the X-ray?
Yes, sir.
Yeah.
This is a plain radiograph of right-sided knee joint, in a anterior, posterior, and a lateral view, showing distal end of femur and a proximal end of tibia and a fibula with a patella. There is bony growth away from the joint with a stalk in the metaphyseal region of the distal end of the femur on the medial side.
Okay.
Without any periosteal reaction, but with the medullary canal is continuous. With the medullary canal of the distal end of femur is continuous with the overgrowth.
Okay, fine. Okay, one more question. It's correct. Good. The why it was actually looks like a 4 by 4 centimeter, and in X-ray looks like tiny.
Very small, yeah. Reason. Anyone else? If
Hello,
yes, Sachin. Yeah,
sir.
yeah.
Because in osteochondroma there is a large cartilaginous cap which doesn't show in X-rays.
Yes, it is good. The osteochondroma, what we see in X-ray is only the bony part. The chondral part, cartilaginous cap, is not visible. So what actually you clinically feel, it is always the more than what you see in X-ray. So that is very important. It is involving the metaphysis, whatever the shape, whether it is a mushroom shape or polycomb-like shape, is bony outgrowth from the metaphysis, and he said that it is that particularly sessile and pedunculated. You can see that bony stalk where it is appearing, it is smaller than the tumor. It is the pedunculated. So this, which is this size? This tumor is this tumor is sessile or pedunculated?
This is pedunculated, sir.
Yes, it is a pedunculated. That's typically said that it grows away from the joint. Okay, the cortex and medullary cavity of tumor is continuous with the cortex and medullary cavity of the bone, and it appears smaller than the X-ray. Okay, one more question here. If it is growing towards the joint, what could be? Anybody has got idea? You need to find out. The tumor, like osteochondroma, looks like going towards the joints. Classically, it is away from the joint. Metaphysis tumor growing towards the diaphysis, doesn't go towards the knee joint. That is very common in case of the Trevor's disease. It is also common. Very rarely we get that, but it is very common. And whenever it is there with that kind of tumor, it will be associated with the restriction of the knee joint. Okay. So anybody can say you would like to do the MRI?
In this case,
Yes.
MRI only when we have compressive symptoms on the neurovascular bundle, if there are any signs.
Okay, fine. Yes, it's correct. It's not wrong that the MRI is not needed in the most of the cases, not required routinely. It's actually indicated whenever you suspect about the neurovascular compression to assess the relationship only that for the neighboring, not needed for the excision.
yeah,
Yes.
that one record.
Not needed for the excision, to know about the assess the relationship of the surrounding structures. When you suspect the malignant transformation, when we say that the cap of the osteochondroma would be more than 5 millimeters. When you suspect the malignant transformation, when pain is sudden increase in size, skeletal maturity, increase in the size. These are the three important sensitive symptoms on that you can think about the malignant transformation. Continuation of that can be well appreciated in the tumor. Whenever you are in doubt whether it is from the bone or not, cartilage cap is also well appreciated. And thickness of the cartilage cap, somebody is going to ask what you are going to assess in the MRI when you can see about the cartilage gap. And sometimes it may show about the bursitis. Can anybody answer what could be the reason of pain in case of osteochondroma? We included some of
Malignant conversion, sir.
one good.
These are fracture of the stalk. If it
Very
is
good. Fracture of the touch. Okay.
Sir, compression of neurovascular structure.
Very good. It's also written. Correct. Something else is also written. Is here. Answer is written already.
bursitis.
Bursitis. Yes, it is also common. It's also in bursitis. So it is also common in such scenario. Wherever there is a sudden increase in size that can lead to the stretching, it's very common to have a malignant transformation. Wherever there is a bursitis, very well said, there is a traumatic injury and fracture or involvement of the neurovascular and compromise the neurovascular, patient will have the pain. And don't neglect the pain in patient with the osteochondroma. The structures around the tumor can also be well appreciated in MRI. So
sir, the answer what we got is like for extent of excision, MRI is indicated. That is wrong.
Yeah,
right, sir?
it's not correct because the excision is not.
Yeah.
We don't require the MRI to excise this tumor.
Yes.
So the final diagnosis is that after the X-ray, not about the MRI, it's a solitary pedunculated osteochondroma. So what will it do?
Treatment.
The excision.
Sir, first of all, observation followed by excision. Sir.
Okay, number one. Anybody else? Observation followed by?
Excision of the sir tumor.
Okay.
In all cases.
Not in all cases, sir.
If the range of motion is affected in
Sir, if it is asymptomatic or minimally symptomatic cases, we will observe.
What we have shown this case, this particular case, that is insidious onset, no pain, no deformity, no neurovascular deficit, no compression. What will you do for this?
So we will try to delay the surgery until the skeletal maturity is achieved, sir.
Okay. What will you do after skeletal maturity?
Sir, resection of the base of the stalk, sir.
Okay. Would you all agree with him?
Anyone else?
No, sir. If the patient is not symptomatic, the patient related to the prognosis and the future of the lesion, and also request them to keep a regular follow-up to know whether there is any malignant conversation or not. And also will tell them if at all they give them a warning sign that if these signs have been experienced, then they can revert back for the treatment.
Okay.
Like pain, increase in the size,
Okay.
and any neurovascular deficit signs and symptoms.
Okay, fine. So actually the correct, what is that the question, as I said, do you need to treat this? Yes, surgical excision, but no, actually this particular case, no, it requires the observation. The indication of the surgery is the first important is the pain, presence of symptoms, the mechanical block because of the tumor it causing the block, the fracture of pedicle, persistent bursite is very common and medial aspect of the tibia. The another indication is cosmetic. If patient wants that, that's why I said the concern of the patient is it the cosmetic or the functional. And the important aspect is the malignant transformation of the tissue. These are the very important indication. Two indication is not written. Anybody can say any indication. Two indication is not written. I have not written that. I will add that the two indication is that number one indication is the growth abnormality. You have mentioned that a couple of times. There is a growth, the cosmetic concern. But would it change management when there is a multiple osteochondroma or diaphyseal eclasia?
Yes, Sachin.
Yes, sir. Sorry, sir. Can you please repeat the question? Can
Yeah.
malignant transformation?
If
No.
it is, yeah, if it is at multiple sites, then
Yes, sir.
the treatment will be same or different.
The question is
Same,
there,
sir.
if it is solitary, Whether
sir.
it's multiple, whether it is different, treatment is same or different.
Sir,
Yeah.
same treatment, sir. No need to excise the other tumors unless until it is symptomatic.
Okay. So there are whenever there is the multiple osteochondroma, you need to examine the neurovascular very carefully. Similarly, you can examine the axial tumor like a scapula or the pelvis. There are higher chances of the malignant transformation and pressure effect. Suppose there is a tumor of the scapula, patient will find out difficult in a lying down position if it is on the dorsal surface. If the tumor is on ventral surface, patient will have the problem with the inspiration and expiration in the lung capacity. So that is a important aspect to examine. Similarly, if there is a multiple osteochondromatosis there, always examine the neurology in quite detail, because you may find out the osteochondroma intraspinal, and it will be very well detected by the careful neurological examination. So beware, in case of the solitary osteochondroma, your entire attention is that at the particular tumor at one side. But if there is a multiple site tumor, you need to examine the child as a whole. And there are highest chances there is a growth abnormality can happen with the multiple diaphyseal eclasia, osteochondroma.
Sir, if it is on the dorsal side of scapula, what investigation, how to diagnose that one, sir?
Yeah, you can do, whenever there is inexhibitable site is there, you can do about the CT scan to find out whether pelvis and the scapula tumor. It is always CT scan is needed, because it will show us that chest compression and pelvis compression, intra-abdominal structures also. Where is there, whether it's inside the pelvis or outside the pelvis. And very commonly, the chondrosarcoma is common in that cancellous bone rather than about the adhesion. So the malignant transformation is less than 1%, but in case of the multiple diaphyseal eclasia, it is very common.
Yes.
Can anybody say if there is yes surgical excision for that? For this particular child, it is no, but yes, because they were cosmetically concerned. So what will you do? What surgery would you do? Somebody wrote the MRI.
Yeah. I think
Marginal resection of the tumor, sir.
Marginal resection, okay.
what is that? Marginal rejection?
Sir, including the cartilage cap with along with periosteum.
So
Sir,
that is
extra periosteal resection of the
that's
tumor.
very important. The answer is correct. So this is the one tumor you don't use about the periosteum elevator. If you use the intraperiosteal or the subperiosteal dissection, because of the periosteum, tumor will recur. So that is the reason people tend to refrain for doing the tumor early. Before skeletal maturity, there are higher chances of recurrence. Second, intraperiosteal resection, higher chances of resection. So suppose we want to do the extraperiosteal excision is the correct answer for that. Entire tumor with the cartilage cap should be excised. Okay, that is the tumor. So anybody can say what type of tumor is this? Is it the
Yes.
Sir, this is sessile.
Yes, it is. This is the X-rays of 3 different patients at the tibia, humerus, and distal femur. Okay, so it depends on that why it is there. Cut down the story. Whenever the lateral aspect of the femur, always check about the common peroneal nerve. Whenever there is a humerus, always see about the neurovascular, whether it is on medial aspect or a lateral aspect. Whether it is on medial aspect, you will get the bursitis. Wherever you'll get the lateral aspect, you will have the common peroneal nerve symptoms. Medial aspect, subvastus or adductor, you will get compression on the popliteal vessel. Based on the posterior aspect, solar plexus will get it affected. So always check the clinical side of the tumor. This is another example where the child has got the multiple osteochondroma, where you can see the posterior aspect of the tibia is on the medial aspect and the posterior aspect. So it will involve the posterior vessels, and very common. This child has got the symptoms on both sides, the right side and left side. The left side on the tibia, while the left side is involving tibia and fibula, and common peroneal nerve was also involved. So you need to decompress it. The important to know what is the indication of the surgery. Indication is not only the cosmetic reason. Pain is one of the indications. Neurovascular compromise is restriction of the range of motion is third. Subluxation or dislocation is fourth. Bursitis fifth. Malignant transformation is the last. Don't forget about the fracture. So this is a case of the multiple exostosis or a diaphyseal ecclesia. What I was showing the child, same child, you can see that the compression on the posterior aspects. Okay, so the neurovascular get compromised, and whenever you palpate the pulsation which is less than the opposite side, further investigation is required, as like this that was showing the pressure symptoms. Okay, that can have the joint restriction. Very common to have a joint restriction in the hip joint. And second, whenever there is a posterior aspect of the either the thigh or a leg, distal femur or a proximal tibia, the range of motion of the knee joint gets compromised. The medial aspect of the femur that will affect the hip joint, and that can lead to the subluxation and progressive dislocation. Very common to have a fracture. You can see there is a fracture on the other side. Whenever you suspect that, you can do about advanced imaging. But the fracture by and large, it will be another indication of doing the surgery. Bursitis, you can see there is a large bursa, very, very common, as I said, in a medial aspect of the tibia. Very common to have a bursitis. You can see the large bursa in the medial aspect. Okay.
Is it compulsory or to close the medullary canal which is continuous with the lesion after excision?
Not close that. You can excise. You can see the pointer here. You can excise up to here. No need for closing. You can keep it to the open, or you can put some bond wax or something on that, so avoid the bleeding. Otherwise, the medullary cavity will constantly ooze, and hematoma formation is very common after the surgery. Any question till now? Should I go on the second case?
Sir, intralesional calcification, do they increase the suspicion? Should that increase the suspicion of malignant transformation?
Yes. It can increase the malignant transformation. I will show you one case.
Yes.
Yes, whenever there is a calcification is there, they can suspect about the malignant transformation.
Sir, in such cases, how to proceed?
So whenever you suspect, if you clinically suspect there is a case of the malignancy, you can do about the J needle biopsy. Once the diagnosis is confirmed, you can do about the wide excision. Because it is whenever you suspect the malignancy, always advanced imaging is required in form of the bone scan and the metastasis workup. So you need to solve malignancy whenever you suspect. You need to do about the chest X-ray and other. And the local site, the chondrosarcoma, very common to be converted from the osteochondroma is chondrosarcoma, and the primary treatment of the chondrosarcoma is wide excision.
So, sir, excisional biopsy should not be done.
Because if you do an excisional biopsy, if you suspect, then you can do the imaging. Once it's imaging will give you a lot of idea. Imaging, yes. There is no cap, there is no calcification in cap. You can do about the excision. And same for the margin.
Yes. Thank you, sir.
Yes.
Any other question?
If anything else for exostosis, then Otherwise, for the next case, we can proceed.
Same exostosis, same case.
Okay, sir.
Can anybody can make this is about other patient. This 12-year-old boy present with the. Can anybody find can figure out what is happening to the both lower limb?
Yes. What deformity it is called?
The valgus deformity on the right side.
We have one answer, windswept
Windswept
deformity.
deformity.
Yes, it's a correct. There is a right side is a valgus deformity and the left side is a varus deformity. So it's not only the windsweep is a pathognomic of the rickets, very common in the growth abnormality also will have the windsweep deformity. So this is the case with the osteochondroma, diaphyseal eclasia, multiple hereditary exostosis with the windswept deformity, 12-year-old boy. What will you do?
So this diaphyseal ecclesia, other name is metaphyseal ecclesia also, sir, or because
No,
in few books.
Yeah, because they said there's a defect in the metaphyseal widening. It's
Okay.
very commonly used because if you see that the metaphysis, it's broadened. There's a loss of the remodeling present in case of the metaphysis. That's why the people will say the metaphyseal dysplasia. But the traditional name is ecclesia, diaphyseal ecclesia.
Yes. Okay, so
So what should we do? How should we proceed?
yeah, anyone? I think we'll start with Avinash.
Sir, the tumor is interfering with growth.
Hmm.
So we should do surgical excision with deformity correction.
In the list, whether you get it that surgical indication is there, but in list, did you find out the tumor excision for the growth abnormality or deformity? Did you pay attention? So if you want to remove the tumor, whether the growth would be fine?
No, sir, because it is 12-year-old boy, the recurrence chance will high, and the damage of the physis is already done.
Okay.
So, so the deformity will increase with the growth.
So what will you do for deformity?
The growth modulation.
Okay, very good. One. Anybody else?
At this age, that is the only surgical option available because he is still having a growth potential, sir.
Okay.
And if at all he has to do another bony procedure, then we have to wait till the cell maturity for corrective osteotomy.
Yes. So it is very important. I agree with the answer. There is wherever there is a deformity is there, we need to consider whether it's a physiological, pathological. This is pathological. Etiology of deformity is diaphyseal ecclesia. As rightly mentioned, it is 12 years, so more than 2 years left. The plane of deformity is only coronal, one side valgus, one side varus. Valgum and varum combination is windsweep deformity. The site of deformity. Okay, can anybody say how can you judge the site of deformity in this patient?
So by finding
Yes.
Yes, Amay.
we will plot. Will find the cora and the correct angle of correction.
How do you find out cora? Good.
Sir,
Cora, what is full form of cora? What is full form of cora?
Don't use the short form, yeah. The exam.
center of rotation of axis.
Rotation of?
Center of
Rotation of angulation, sir.
Rotation. Angulation, not axis. Angulation. Okay.
Yeah.
So that, because these are the question is very standard question. Whenever you will see any child with deformity, irrespective of whether it's a hereditary multiple exostosis or not, you need to consider this many points for the deformity correction in a child. So the site of deformity, how would you judge clinically? How would you judge radiologically? Any test for the postgraduate? Very commonly asked that Genuvaram and Valgam is your exam case for the DNB, MS.
We request the patient to flex the knee joint. If the deformity disappears, then the deformity lies with the femur. Otherwise, if it persists, it lies with the tibia.
Correct. So it is very important to do the flexion test. So whenever the knee deformity is there, always flex the knee and find out whether it is femoral component or a tibial component. Okay, how do you find out in radiology?
Radiology is by finding, sir, center of angle and center of rotation of angulation, sir.
Okay, it is not always center of. For that, you need to measure the angle. Angle is there, distal femur tibial angle. You need to say the mechanical axis. Okay, I'll go back to the excellent say. You need to draw a mechanical axis of the right side, which is falling on the lateral side. If you draw a left side, the mechanical axis is falling on the medial side. Once the mechanical axis is fall on the lateral or medial side, that will give an idea of whether the deformity is valgus or varus. Once valgus deformity is there, you need to draw a mechanical axis of the femur and mechanical axis of the tibia, and whether the mechanical angle of the mechanical axis of distal femoral angle is abnormal or not. If it is 87 degree, it is normal. Similarly, mechanical axis of the proximal tibia, whether it is normal or abnormal. So that's how you find out whether the angle is increased, that shows about the tibial component. If angle is decreased, it shows about the.
So can you repeat, sir? Your voice has disappeared in between.
Okay, so you need to measure about the angle. Mechanical distal femoral axis angle. Similarly, the mechanical proximal tibial angle. Clear? So by and large, it is around 87 to 90 degree. If the valgus is there, the proximal medial tibial angle is increased. Then that is a tibial component. If there is a distal femur is there, that angle is decreased. Okay, that's the difference between the femur and tibia. So if somebody is going to ask what is the deformity, that is a femur or tibia. Severity, yes, again you need to measure about the angle and the complication like limb length discrepancy. Why these are all important? Because you know the answer, it's a growth modulation. When you judge all the variable, you can predict how much time it will take to correct the deformity.
And so probably they all should know about the mechanical axis, what it is before, if it, then they can understand. Yeah. And by convention, as sir mentioned, that for the tibial side it is MPTA, and for the femur side it is the distal femoral lateral side angle. So that is you should know. Yes, sir.
So it's written for you all five the option, but I'm cutting short the story. We need to go for the hemiepiphysiodesis of the femur and tibia. Observation, it is going to progress, so it's not a good option here. Bracing, when it's established deformity, it's not a irreversible causes. We can use the orthosis. Treatment of the cause, we cannot change about the bone dysplasia or hereditary multiple oxystosis. It is particular treatment of cause for the rickets, where it's a reversible medical disease, not a surgical disease. The hemiepiphysiodesis is the option for a child. Once the skeletal maturity or the near maturity, it's yes, hemiepiphysiodesis will have a role in the early correction. It's correct. Okay, so this child has been treated with the medial side, on the right side, and lateral epiphysiodesis on the left side, and we can see the mechanical axis is getting it corrected. At 12 months, it's perfectly got it straight. You can see the blue line is the mechanical axis. And it's a very important message. The child should be followed for the skeletal maturity because it can happen the rebound or recurrence. Undercorrection and overcorrection is also common.
Yes, sir. So that one thing I think if all the postgraduate will notice that one side it is both tibia and femur, and in another side it is only femur.
Yes.
The reason, yeah.
The reason is the site of deformity. If you see the mechanical axis of the tibia is straight on the left side.
Yes.
That
Yes,
is important for the planning of deformity. Nothing has been done for the osteochondroma. So this is the deformity of. Okay,
yes.
so it's been maintained. It's a growth modulation. Once it has been there, it gets corrected. These are the contraindication. I'm not going in detail. The overcorrection is also common. This is a case happen with deformity. So we'll come to the deformity where it can common in the forearm. It can common in the distal femur and proximal tibia. Okay, any question here?
Anyone, if have any doubt, please ask right now. Then we'll move on.
So in the first case, you said the GCT is epiphyseal and not metaphyseal, but book says in the pediatric age group it is metaphyseal and in adult age group it is epiphyseal. Can you throw some light about
GCT?
GCT is not common in a child. GCT is once it has been fused. Which textbook mentioned GCT in metaphysics? GCT is not there in there.
Metaphyseal in children?
Where did you find out?
It is mentioned the book name. If
can you find out send me the reference on that. GCT is not common in a child. GCT is always epiphyseal, and it is always after the physis. Whenever you'll see the epiphyseal tumor involving epiphysis, commonest diagnosis is chondroblastoma, and second differential is the infection. GCT is exceedingly rare, though it is not that zero report, but it is exceedingly rare. Few case reports are there, not there in the child.
If similar thing is in metaphysis, that is aneurysmal bone cyst, that one that looks like GCT, but that is as sir mentioned, that is not before the epiphyseal fusion.
Yeah, this is a 21-year-old male presented with the swelling since 10 years. Is there any difference between what we discussed the last time? Last case?
Yes.
Actually, this is the last case. We'll stop after this. This is the last case. But any difference between the last case and this case? Can anybody?
Sir, massive swelling. Patient age group is 21 year. That means after skeletal maturities.
Yes, but this you see the history. It's a swelling since
10 years.
10 years. So.
And the swelling is exceeding
adolescent.
Mid diaphyseal region till the mid thigh.
So these are the points which are already included. This is X-ray.
Sir, prominent veins can be seen.
Yes, that is there in the clinical aspect. It's actually the swelling was huge. Actually, the skin is tiny and there is a prominent vein is visible. So in those cases, when there is a swelling is there in long standing, you can think about the malignancy. You can do about the MRI and you can see the cartilage cap, the calcification. But again, it is well defined. It is no soft tissue infiltration here visible. But this is a suspicious case. Okay, in that suspicious case, you can proceed with the safety by the biopsy because it is required wide, or you can treat with the extraperiosteal resection as a full. So child has been treated with the extraperiosteal resection, and the margin you can send that. These are the important point. Rapid increase in size in the slowly growing tumor, increase in size of previously known tumor, pain appears if it is a painless swelling, and increase in local temperature. And whatever we discussed couple of times, chondrosarcoma is common, very common in the diaphyseal ecclesia or multiple osteochondroma, very less in case of pedunculated tumor. It is more in sessile tumor, and biopsy is needed for the surgical planning. Okay, these are the very important points of the osteochondroma. I'll stop it here. Any question is there? We can have some question.
Yes, sir. So one thing which I think it should be mentioned, that how to say diagnosis in the exam for a tumor case.
Yeah, I have mentioned that in the this one. That's is it a benign or a malignant tumor arising from X particular bone? Okay, whether it's a solitary or multiple, whether it is a complicated or uncomplicated. If it is complicated in terms of growth abnormality, deformity, distal neurovascular, bursitis, or a malignant transformation.
So I think if
Sir, in case of diaphyseal ecclesia, can we keep malariostenosis as a DD?
Malariostenosis is not
there
a
is
differential diagnosis of hereditary, because hereditary multiple exostosis is bilateral and symmetrical, while malariostenosis is always involving unilateral. And malariostenosis will not present like a bony outgrowth. Malariostenosis is osteosclerotic type of skeletal dysplasia affecting bone and soft tissue, involving only one side of body.
yeah, that classical sign they can ask for the exam. Other name, I think Lery's disease is a name for that. Any other question if you have? I think it was quite well covered about the basics of tumor, how to say in the exam. Although few X-rays that need to be discussed, like Ewing sarcoma and all, for that one I may request you whenever you have the case in.
Yeah, I will check that and I will get that back.
Yes, sir.
I thought this is very basic for them to have in useful for the exam, OSCE
Yes.
and table wire, all three, because osteochondroma is very basic tumor.
Yes, sir. And usually they ask also, so if it is there in the hospital, it must be a short case.
Yes, it's
Yes.
easily available also because it's the most benign tumor, most common tumor.
Yes. So I think for today, if anyone have any question, you can ask. Otherwise, we may proceed, sir.
Okay, it's exactly 1 hour. So
Yes, sir.
fine, we'll stop it here.
Yes, thank you very much, sir. It was quite informative, and I think it's very useful for the exam going batch.
Okay.
Thank you so much, sir.
See you then. Bye.
Thank you, sir. Thank you very much.
Good night. Good night.
Good night. Sir.
तो बच्चों कभी की प्लेट लगता है बेचारे ने कुछ खाए नहीं। That is okay. बच्चों ने खाना नहीं खाया।